I'm a consultant respiratory physician and specialise in ventilation medicine. And I'm really talking to you as an interested physician and scientist. I know that many people on the call will have great experience in using high flow therapy, whilst there might be some more novice people out there. So I hope to today cover a few different bases, including the mechanisms of benefit of high flow, but then also look at the evidence for using high flow in both the acute and chronic setting. It's rare that you get an hour to talk to a subject these days, but it can be something of a blessing and a curse, making you believe that you can cover everything, which clearly won't be possible. With the time that we've lost already, it might be that I'll have to skip through a few slides, but this slide deck is really a resource for any interested individuals, so that you can go back and review the data within. I have tried to include references for all the data shown, so that, like I say, you can go back and review at your leisure. I realise that there are likely to be a number of people with English not as their first language, so I will try my best to speak coherently and slowly enough to be understood. I apologise if I fail to do that at any time. So first of all, when we talk about high flow nasal therapy, what do we mean? Well, we're talking about any system really that includes a flow meter, an air oxygen blender and a humidifier. Typically, it allows gas to be delivered at up to 60 or 70 litres a minute, and with an FiO2 and inspired oxygen concentration up to 100% and fully saturated with water. And this is what some of the kit can look like in the acute setting. And this is not new technology. So in fact, it was first developed way back in 1960s and was used in neonates in the 70s. It's taken some time to migrate to adult care, and in the interim we've developed other forms of respiratory support, including CPAP and NIV. And it's only really in the last 10 years that it's migrated to adult care and then out of adult care. But you can see by this simple graph of publications using a search term of high flow nasal therapy that the interest in this therapy has skyrocketed over the last few years. The recent dip needs no explanation, I'm sure. Such is the interest that this is now a big business. So it's expected to be worth around $9 billion US in just a few years' time. Possibly because of that, but also because of its breadth of potential use. There literally seems to be a new paper of worth being published almost weekly with new indications and concepts. Trying to pick out the important data and the reliable data from these is one of the challenges. So just to run through the mechanisms in brief, I'm sure many of you will already be aware of this, but one of the main advantages of high flow nasal therapy is its ability to deliver high levels of inspired oxygen. And this is in comparison to other forms of oxygen delivery, such as a face mask, nasal cannula, or a non-rebreathe mask. This study demonstrates some of those issues, and we can see here that with a 12-litre Hudson mask or even a 15-litre non-rebreathe mask, we're limited to FiO2s below 70%. Compare that to a high flow nasal therapy device here running at 40 litres a minute, and we can see that you can achieve much higher FiO2s toward the 0.9 or even above. Another issue with our usual ways of delivering oxygen therapy is that they are liable to alter the amount of FiO2 delivered in response or as a consequence of patient inspiratory flow demand. And that's because their flow rates are limited. As the patient inspiratory flow demand exceeds that can be delivered by the mask, air is drawn in from the environment and dilutes that delivered oxygen. The study here actually demonstrated this by way of creating a higher respiratory demand by binding the chest. so that the individual's respiratory rate increased. And in so doing, you see that the problem is amplified, particularly at the lower flow rates, so 15 and 12 litres per minute. By increasing the respiratory rate and respiratory demand, the FiO2 falls. Again, with high flow nasal therapy running at 40 litres a minute, this is not a problem. Interestingly though, that level of FiO2 of around 0.9 was achieved with a delivered oxygen at 1.0, 100%. And there's reason to believe that the actual inspired delivered FiO2 is somewhat lower, and that's because of sampling error. That previous study used a indwelling catheter in the nasopharynx to measure the level of oxygen in the airway. However, we know that there are different turbulent flows within the airway, meaning that one sample point doesn't necessarily represent the overall delivery. Perhaps a more robust way of assessing this is using the alveolar gas equation and calculating the delivered FiO2 based on the expired gases. And in so doing, we see that it's only on achieving flows of around 50 litres a minute that you can achieve the desired FiO2 here, 0.6. In blue is a person with their mouth closed. In keeping with what we've just discussed, as the inspiratory rate increases, the delivered FiO2 can decrease such that during exercise, here in green, the delivered FiO2 is significantly less than that the machine is set at. And this is all worth considering, especially when we consider patients who have high inspiratory demands. I put this in for reference and to mention, particularly given the recent concerns with COVID, particularly in the UK, or at least in the UK, where oxygen demand became a limiting factor, or oxygen capacity became a limited factor, we can accurately calculate the amount of oxygen demanded in high flow nasal therapy systems. And that's set out in this table here for reference. But aside from this assured level of FiO2, there are other benefits to high flow nasal therapy. It's now widely accepted that high flow nasal therapy generates a degree of positive pressure in the oropharynx. Here in post-surgical patients, mean pharyngeal pressure was measured, and it was noted that there was a linear increase in mean pressure according to flow rate, with about a 1 centimetre increase per 10 litres per minute high flow rate increase. That pharyngeal pressure alters through the respiratory cycle such that the peak pressure is felt somewhere around end expiration. And it might be unsurprising to learn that depending on whether the mouth is open or closed, the pressure generated varies. So pressures are much greater with the mouth closed than when the mouth is open. Some studies have suggested that the expiratory pressure can rise to around 7 centimetres with the mouth closed. And this begs the question as to whether that pressure is transmitted to the lower airways and potentially increase alveolar ventilation. Here, that question was addressed by looking at lung impedance as a measure of lung volume. And they noted that with high flow therapy delivered at 40 litres a minute, there was a significant increase in end expiratory lung volume compared to ambient air. That was noted whether the patient was supine or prone, although in the prone position, the increase in ventilational volume was more homogeneous. And it's not just volumes, but breathing pattern that high flow nasal therapy can impact on. Here we see a study in healthy individuals looking at tidal volume and respiratory rate. And we see again a flow dependent linear increase in tidal volume according to the flow delivered. In regards to respiratory rate, again, there is a relationship to flow with a decreasing respiratory rate as flow rate increases. This changes when we're asleep, such that In wakefulness, as just illustrated, there is an increase in tidal volume, a decrease in respiratory rate, but overall a steady or maybe slightly increased minute ventilation. However, in sleep, the respiratory rate does not decrease so much, but the tidal volume does decrease rather than increase, such that the minute ventilation overall can slightly decrease. And this is important when we consider how we might employ high flow nasal therapy in a patient population, which we will talk about later. It's important to note that not only in health but in disease we see these impacts, and the changes occur very quickly. So this is a study looking at high flow nasal therapy at 40 litres a minute in a hypoxic patient population. And we can see that immediately after starting high flow nasal therapy, there is an impact on respiratory rate. There is, of course, also a very early impact on SpO2 and oxygen delivery, as would be expected. Other proposed benefits of high flow nasal therapy include mucus clearance and humidification. Whilst this makes great physiological sense and clinical sense, it's quite difficult to show in research studies, and the data are few. However, this is a clinical study that looked at the clearance of labeled beads from the airway in patients with impaired ciliary function. And over the course of 6 days, using high flow nasal therapy for 3 hours per day at a flow rate of 20 to 25 litres per minute, they saw that there was an improvement in clearance, such that the clearance half time significantly decreased after a week of high flow nasal therapy. Supporting this study was data produced by Burke slightly more recently. They used patients who had just had a tracheostomy formed and applied either high flow nasal therapy or standard care in terms of oxygen therapy. They measured the number of tracheal suctions required, but also sampled the airway and looked at the ciliary beat frequency. They saw both a decreased number of tracheal suctions required in the high flow nasal therapy group and also an increase in the ciliary beat frequency. So this speaks to the fact that the humidified airway generated with high flow nasal therapy is healthier and more effective. Some of the other effects of high flow nasal therapy include dead space washout. This was a neat study demonstrating that, whereby radiolabeled gas was used and imaging of that gas to calculate the clearance and where that clearance occurred. And they saw that, similar to previous data, there was a linear relationship between the flow rate of nasal therapy and the clearance half-time of that bolus of gas. Interestingly, they noted that the clearance seemed to occur beyond the soft palate, suggesting that the washout occurred not just in the upper pharynx, but in the lower airways. To test that, they did a second study which measured the carbon dioxide levels at the tracheal level in patients with tracheostomy. And indeed, they saw that the tracheal clearance of CO2 also responded to high flow nasal therapy, again in a flow dependent manner. Of clinical significance is the concept of comfort and its relationship to both flow and temperature. This study was conducted in a patient group with hypoxic respiratory failure. In the first graph, we see that at both flow rates of 30 and 60 litres a minute, there was a preference for a lower temperature, so 31 degrees as opposed to 37 degrees. In terms of flow, there was no significant difference in the whole population, but when looking at the sicker population with an FiO2 requirement greater than 45, there was a preference for higher flow, likely because it was better meeting their respiratory need. So this talks to how we might consider setting patients up on high-flow nasal therapy. It should be said that whilst patients might find 31 degrees more comfortable, there are advantages both in terms of the airway physiology and oxygen cost of breathing to having a 37 degree inhaled gas. But perhaps we start patients at a lower temperature and increase. Alongside those data are data supporting the concept that high-flow nasal therapy decreases the work of breathing. Here, using an esophageal Doppler balloon, the transdiaphragmatic pressure was measured, and measures of inspiratory effort and work per breath were generated, showing that there was a decreased work of breathing with high-flow nasal therapy delivered at 40 litres a minute compared to mask oxygen therapy. In that study, they showed that, as would be expected, the respiratory rate decreased, but there was no change in tidal volume, such that the minute ventilation actually decreased. However, the carbon dioxide level did not appreciably change, and they proposed that this was because the breathing efficiency improved. So work of breathing decreased and CO2 generation reduced. So we've seen a number of mechanisms of action, all of which potentially can benefit patients in different situations. So now turning to some of the clinical data, we can imagine how we might employ high-flow nasal therapy to benefit our patient cohorts. I won't dwell on this, but refer to this nice review in the Blue Journal, detailing the mechanisms by which high-flow nasal therapy might benefit patients in hypoxemic respiratory failure. But this is the study that really put high-flow nasal therapy on the map, so to speak. And in it, the group randomized patients with hypoxemic respiratory failure to either standard oxygen therapy, NIV, or high-flow nasal therapy. The primary outcome measure was intubation within 28 days, with secondary outcomes of 90-day mortality, ventilation-free days, and ICU length of stay. 310 patients were randomized, and high flow was delivered at 50 litres a minute. These patients were sick with a high respiratory rate and a low PaFiO2 ratio. Looking at the whole group as a whole, there was no significant difference between the treatment groups, although perhaps a trend towards benefit of the high flow group. However, in a post-hoc analysis looking at those patients with most severe lung injury, there became a significant difference between high flow therapy and the other two groups. Now, there are issues with the study, and not least the switching between groups. But that said, looking at the group as a whole, there was an increased ventilator-free days and reduced 90-day mortality. And as we've seen in severe hypoxemia, high flow reduced intubation rate. Since then, there's been plenty of studies published, such that reviews have been able to produce forest plots like this, detailing the strength of evidence in favour of high flow nasal therapy. Certainly in comparison to standard oxygen therapy, in acute hypoxemic respiratory failure, high flow nasal therapy wins. The case is less obvious with NIV, but still tending towards high flow nasal therapy as potentially of benefit. The story in immunocompromised is slightly different. Here, the patient group was thought to particularly benefit from NIV. So in a post-hoc analysis of the same cohort, the question was studied as to whether high flow nasal therapy was better than NIV in that setting. And you can see here that in regards to intubation, indeed it was. Although there was no significant difference between high flow nasal therapy and standard oxygen therapy. This, of course, was a post-hoc analysis with all the considered limitations of that. And therefore, this study is of interest as a prospective study in the same patient group, and this time looking at that question of whether high flow therapy or standard oxygen therapy should be the preferred treatment strategy in this group. And in terms of their overall mortality, which was the primary outcome, there was no difference. This is somewhat surprising given all those benefits we've just discussed of high flow therapy over standard oxygen therapy. Which introduces the important concept of the potential harm of high flow therapy in this context, and that really relates to delayed intubation. So one of the difficulties with high flow nasal therapy is that patients can often look quite well on high flow nasal therapy whilst being very sick. In fact, they can report feeling better with the therapy whilst their underlying disease deteriorates. In these two studies, it was shown that delaying intubation for those that ultimately needed intubation worsened outcomes. In the first study, patients who were intubated before 48 hours did significantly better. In the second study, delaying after 12 hours had a significantly negative impact on outcomes. Therefore, great interest is had in trying to identify those patients who are going to do well with high flow therapy versus those who will do less well. Looking back at the cohort from the 2015 study, in regard to high flow nasal therapy, in fact, it was only heart rate that had any predictive strength in terms of who would benefit from high flow nasal therapy. So that's a response to heart rate in the first hour. However, again, post hoc and with dwindling numbers to analyse. Instead, other groups have looked prospectively at data in order to try and identify factors to allow the clinician to better predict. And the ROC score is one of those. I'm sure many of us have now heard of this, particularly in reference to COVID. But indeed, the measure is validated in hypoxemic respiratory failure in the setting of pneumonia, and we should remember that. But this is the ratio of SpO2 over FiO2 to respiratory rate, and using a cutoff of 4.88, you can usefully identify those who are likely to do well with high flow at 2, 6, and 12 hours. I won't go through this in depth, but refer you to this very interesting article from Ricard, whereby they set out how the ROC score might be used in a clinical setting to identify those patients in a more meaningful way. In view of time, I won't dwell on the issues around extubation, but I think there is a useful message within this, so I will cover the slides. So, high flow nasal therapy has been employed in the post-extubation setting as a way of preventing reintubation. And there's plenty of data now showing that indeed, compared to standard oxygen therapy, high flow nasal therapy has benefits both in achieving higher saturations, reduced CO2 and reduced respiratory rate. It is often shown, as in this case, that the reintubations are caused by difficulty to clear secretions or hypoxia, and therefore you can imagine how high flow nasal therapy would be of benefit. This is another study that showed again that high flow nasal therapy in this setting has a definite advantage. However, when looking at high-risk patients, the situation is slightly different. In this scenario, non-invasive ventilation is the standard of care, acknowledging that the patients with high risk of reintubation require that extra level of support. So in this study, they compared high flow nasal therapy to non-invasive ventilation, and it was a non-inferiority study, and indeed, high flow nasal therapy was non-inferior. However, it was considered that rather than using these therapies distinct from one another, as in the previous study, perhaps using them in combination would confer additional benefit. And this is what this trial demonstrated. Rather than using high flow or non-invasive ventilation, they used either high flow or a combination of non-invasive ventilation and high flow. And they showed that in that combined group, there was a significant benefit compared to high flow alone. And I showed this not only for this setting, but also when we consider how we might use high flow. It doesn't have to be high flow, or it could be high flow and. So far, we talked about care in the ICU, and any of us involved in the ventilation world will be aware of the difficulty in extrapolating findings from ICU to non-ICU environments. So if we look at some studies investigating high flow outside ICU, we can try to understand whether it's safe and effective. So this was a simple before-after study from the French group, looking at high flow nasal therapy for patients presenting to the ED in respiratory failure that judged as increased worker breathing or respiratory rate despite 15 litres of oxygen. The primary outcome was proportion improving in respiratory rate or work of breathing. It was 100 patients or so, and high flow was delivered at 50 litres a minute. And indeed, they saw that there was a significant decrease in respiratory rate in the high flow nasal therapy group, and a significant improvement in the work of breathing in that same group. It should be said that there were no differences in the secondary outcomes of hospital length of stay or intubation rate. Other groups have looked at the same question, often in slightly different ways with slightly different outcomes and endpoints. This study looked at high flow nasal therapy versus standard oxygen therapy outside of ICU in the ER. Their inclusion criteria was broad, so saturation is less than 92% and respiratory rate greater than 22, so this is almost all comers. Primary outcome was conversion to NIV, CPAP or intubation. High flow is delivered at 40 litres a minute, 37 degrees. Standard oxygen at up to 15 litres a minute. And what they saw was that there was no significant difference between high flow therapy and standard oxygen. Moreover, there were a significant number of patients in the high flow nasal therapy group that found it uncomfortable and would not be happy to have it again. So from this study, we can say there was no difference in the rate of intubation or hospital length of stay or 90-day mortality, perhaps suggesting that high flow doesn't have much of a role outside of ICU. However, I should note that this was a very mixed group of patients with a number of different presenting pathologies. And also the expected response in breathing frequency to high flow nasal therapy wasn't seen, which suggests that there was something in the way this was delivered, or perhaps to the patient group it was delivered to, that was suboptimal. So perhaps better patient selection, or perhaps high flow nasal settings might have had a greater impact. However, I think it's fair to say that indiscriminate use in ED in place of oxygen is unlikely to be of benefit. Turning now to NIV. And asking the provocative question as to whether high flow nasal therapy is better than NIV. And I'll have to run through these slides slightly quicker than planned, but please do go back and read papers if interested. So this patient by Doshi is often cited as evidence for high flow nasal therapy being effective in treating hypercapnic respiratory failure. They randomized in non-blinded way to NIV or high flow therapy. High flow therapy was delivered at 35 to 40 litres a minute, and NIV with an IBAP of 10 to 20 centimetres, aiming for SATs of greater than 88. Primary outcome was failure of therapy or intubation within 72 hours. It was a non-inferiority trial, and it was a positive trial insofar as high flow nasal therapy was proven to be non-inferior to NIV. They also showed that both groups, in both groups, there was an equal reduction in CO2, suggesting again that hyphenase therapy is just as effective as NIV in treating hypercapnia. However, there are significant issues with this study in drawing those conclusions. This was mixed etiology. Some patients were hypercapnic, others weren't. 40% had a PCO2 less than 6. Diagnosis was unclear in many, and 36% or so of patients had a diagnosis of general dyspnea rather than a more accurate diagnosis of their presenting pathology. There were no initial ABGs, and I would argue that the NIV pressures used were suboptimal. Finally, this was only 4 hours of treatment, which perhaps was too short to see benefits or, in fact, limitations of high-flow nasal therapy. So I'm not sure we can draw too many conclusions from this. Better design studies have been published in recent years. This is an interesting study from Sun, in which they investigated the question as to whether high-flow nasal therapy was non-inferior to NIV in moderate hypercapnic acute respiratory failure, patients having at least a CO2 of 6.7 and a PO2 less than 6 and a diagnosis of COPD. They compared non-invasive ventilation, high-flow therapy over the first 4 hours, and primary outcome was treatment failure. Again, they saw little difference between the high-flow group and the non-invasive ventilation group, either in failure rate or survival rate. Again, this might suggest that the two are equivalent. However, again, I would point out some limitations, not least the fact that this was non-randomized and retrospective, and the treatment decision was made by the treating clinician rather than a priori. The NIV group again had quite low intensity NIV, much lower than perhaps guidelines now would suggest. And the treatment duration of high flow and NIV differed significantly. That could be said to suggest high flow is better tolerated, but it certainly would ask the question as to whether NIV was given the opportunity to be effective. The NIV failure rate was also much higher than would be expected, and the primary diagnosis in both groups was pneumonia in 40%, a group that we know does badly with NIV. So we might say that high-flow nasal therapy might be non-inferior to perhaps subtherapeutic or non-optimized NIV in a hypercapnic respiratory failure. Better tolerated, but not necessarily better. This study I won't go through in depth, but there's another study looking at high flow versus NIV, this time though with more effective NIV pressures being used and a well-defined patient group, though still retrospective. Again, they showed a non-inferiority, but again there are some issues with the study insofar as there was a very small decrease in CO2 in the NIV group, almost little change over 6 hours, which is not what we expect when delivering NIV to a patient with COPD. The time on mask was not reported, and again the intubation rate, the NIV failure rate, was higher than we would expect. Of note, treatment length was also longer than we would expect, with NIV of 8 days and high flow of 7 days. Again, pneumonia was prevalent, but also cardiogenic pulmonary edema. So NIV is being used or employed in these scenarios outside of the setting that we know it's most effective in. I will mention this study, acknowledging that we don't have too much time left, but certainly it's worth going away and looking at. This is a recent study and well-designed prospective non-inferiority trial between high-flow nasal therapy and NIV. Primary outcome was change in CO2 at 2 hours, with a whole plethora of secondary outcomes of all the type that you'd expect in a study of this sort. Non-inferiority was considered with an interval of 10 millimeters of mercury, or 1.3 kilopascals. High flow was delivered at 60 litres a minute, and NIV aiming with it for a tidal volume of 6 to 8 mils per kilogram, ideal body weight. pH across the group was 7.3, CO2 was high at 9.7, respiratory rate 27, and the groups were well matched. And we see that the two groups were also well matched in outcomes in change in PCO2 and actual PCO2. There was a trend towards a greater and quicker decrease with NIV, but that didn't reach statistical significance. Furthermore, the high flow nasal therapy group reported less discomfort, and there were no difference in secondary outcomes. However, what's really interesting in the study, I think, is that whilst certainly high flow nasal therapy works for some, 32% of patients switched from high flow nasal therapy to NIV within those first 6 hours. Moreover, those that switched to NIV had a longer length of stay than subjects that were randomized to NIV from the beginning. A non-inferiority margin that was greater or less than 10 millimeters of mercury, had we chosen a tighter margin, would have had different outcomes, and some data that I would have liked to see was not displayed. So I think we might conclude that high flow nasal therapy is non-inferior to NIV in reducing CO2 in mild moderate hypocapnic respiratory failure, but we need to acknowledge that a significant number of patients fail, and those that fail seem to do worse. So prediction is going to be very important. NIV, I would argue, still remains the gold standard. A couple of studies before we leave this topic. This looking at using high flow nasal therapy in combination with NIV to support patients whilst on breaks from NIV. And what was shown was, as we would expect in keeping with our earlier discussion, high flow nasal therapy led to less of an increase in respiratory rate during breaks, less breathlessness, and greater comfort. However, it did not actually extend the time off NIV, which was the primary outcome for the study, nor did it reduce the NIV treatment length. And high flow nasal therapy, though, was more comfortable. There are some issues with this study in the way that the breaks were decided when patients would have to go back onto NIV. And there's still reason to believe that high flow nasal therapy is of benefit. This physiology study from 2019 showed that in comparison to standard oxygen therapy, during breaks from NIV, high flow nasal therapy significantly decreased the work of breathing as measured by the thickening fraction of the diaphragm. So not only do patients feel less breathless and more comfortable, but they're working less hard. I'm eager to see the outcome of this study, which I believe has finished recruiting, or soon to, which looks at the question with much more tighter criteria around the breaks from NIV and when to restart therapy. And I hope we'll answer this question decisively as to whether high flow nasal therapy can be of benefit in these situations. A few more slides before I'm happy to take questions. Looking at the chronic setting rather than that acute setting, we know that in the acute setting, when CO2 levels are high, PO2 levels are low, and work of breathing is high, high flow nasal therapy is likely to have an effect. However, in the chronic setting, it might not be so obvious. There is physiological reason to believe that it would be effective. This study by Laura Pisani, published in Thorax in 2017, investigated the physiological change of conferred by high flow nasal therapy in a group of hypercapnic but stable COPD patients, using high flow therapy at 20 and 30 litres a minute and comparing to NIV. there was the expected decrease or increase in tidal volume and a decrease in worker breathing, again measured by the pressure time product. In this study, at least, there was little change in CO2. However, the length of time for these treatment trials was very short, just 30 minutes, so perhaps not long enough to see an effect. More convincing evidence comes from a series of papers by the Brandlich group. They looked at the same question as to whether hyphenase therapy might reduce CO2 in patients with chronic stable hypercapnia. And in this physiology study of 15 patients, they showed that indeed it can. So breathing frequency decreases with high flow, tidal volume increases, minute ventilation slightly decreases, but CO2 appreciably decreased after 8 hours of therapy. In a follow-up study, they investigated as to whether that decrease in CO2 was because of washout of dead space or decreased work of breathing. In 54 individuals, they measured the mean inspiratory airway pressure generated by the high-flow nasal therapy, and then looked at the percentage change in CO2. And what they found was that there was a significant difference in the CO2 in high-flow therapy conditions of 20 litres versus 30 litres. Now that's important because there was a very little increase in airway pressure between 20 and 30 litres, suggesting that that would be too little to confer any particular change in work of breathing, and therefore dead space washout must have been the mechanism. Further evidence came from, again, a follow-up study to that, looking at the CO2 change in various conditions of high-flow nasal therapy according to leak and flow. And what they saw was that with increasing flow, but also in conditions of higher leak, the CO2 decreased from baseline in an almost linear fashion. And it was concluded that in chronic stable hypercapnic COPD, high-flow nasal therapy reduced CO2 primarily through dead space washout, although I would argue that reduced work of breathing may also contribute. How this translates to real life and where high-flow nasal therapy might sit within our treatment modalities is still a question under investigation. The same group looked at that question using a randomized crossover trial between NIV and high-flow nasal therapy. They looked at 100 patients with a CO2 of greater than 6.6 kilopascals, and the primary outcome was a reduction in CO2. Patients had an average CO2 of 7.4, and high flow was delivered at approximately 20 litres with NIV of 20 over 4.5. And you can see from the graphs that there was a significant number of patients in the nasal high flow group that benefited in terms of CO2 reduction. From this, we might conclude that high-flow nasal therapy in that setting can reduce CO2 to a similar degree to NIV, though this was only after 6 weeks. And of course, a reduction in CO2, whilst it might imply other benefits, is not a clinically important aim in itself. Instead of using it in preference to alternative to NIV, perhaps high-flow nasal therapy might be used instead of or in combination with oxygen therapy in the long-term oxygen therapy setting. And this is what Nagata investigated in this trial, which was a crossover trial of 6 weeks duration between LTOT and high-flow nasal cannula plus LTOT. The mean time spent on high flow in both groups was around 8 hours with a mean flow of 30 litres a minute. And the main outcomes were that there was a significant decrease in CO2 with the high flow nasal therapy of what's generally accepted to be a reasonable degree of change of 0.5 kilopascals, and that was also seen at night. And there was a significant improvement in quality of life scores. However, perhaps even more important is this study by Sturgard from 2018. In it, the group randomized 200 patients with COPD on LTOT to either usual care or high-flow nasal therapy for 8 hours per day. The primary outcome was exacerbation rates over 12 months. The groups were fairly well matched, although the high-flow nasal therapy group were more breathless at baseline. Average use was about 7 hours per day. 53% used it at night solely, 32% during the day, and 15% day and night. And this was a positive study. The high-flow nasal therapy group experienced significantly fewer exacerbations than the standard care group, as well as fewer admissions. Not only that, but the PaCO2 level in the high-flow group was maintained, whereas in the standard care it increased, such that at 12 months there was a significant difference. 6-minute walk test distance improved in the high-flow group and decreased in the standard care group, such that again at 12 months there was a significant difference. There are issues with the study, not least the 40% or 44% dropout rate, but nonetheless this is a very interesting study and certainly begs the question as to whether high-flow nasal therapy might be additionally beneficial in this patient group used in this way. I'll skip through these last couple of slides to leave a little bit of time for questions, but just to point out the main points, domiciliary high flow has been studied in bronchiectasis. The data are not many, but do point towards potential benefit. This study looked at using using high-flow nasal therapy in a group of patients with bronchiectasis. The average use was only 1.7 hours per day, but even with that limited use, there was a decreased rate of exacerbations. And when we consider exacerbations in bronchiectasis to be prolonged and difficult for patients, that reduction is really important. This was a post-hoc analysis of a previous paper with a group of COPD patients who also had bronchiectasis. So there is a need to study this question in greater depth with perhaps a prospective trial design. Second to last slide to reassure those listening. We talked so far about using high-flow nasal therapy, usually with high flow but low oxygen requirements. However, it is possible to use high-flow nasal oxygen, and I mean that to say higher FiO2 deliveries in the domiciliary environment. So this was Maxime Bertout's group in France, and they reported their experience of using high FiO2 high-flow nasal therapy in a group of patients with end-stage lung diseases. And they showed that this is feasible and, you could argue, effective. So they discharged 51 patients to home, 55% of them requiring liquid oxygen, a mean number of tanks of 4, and achieving an FiO2 of 63%. The mean survival was 3.6 months, and the costs were also assessed as a setup cost of approximately €1,700 and a monthly cost of €520. And cost analysis has been performed in this setting and judged to be worthwhile financially, so to speak. And this is a patient group who might otherwise not be able to leave hospital. So this is really important data, I think. Finally, I will mention sleep apnea, because surprisingly, there's not much data supporting high-flow nasal therapy use in this setting. However, I do think there is potential role. In this study, they looked at high-flow nasal therapy in a group of patients with sleep disordered breathing. To summarize, they found that high-flow nasal therapy can significantly improve sleep disordered breathing, but really only those with obstructive sleep disorder breathing rather than central, and again, really only those with hypopneas rather than apneas. But certainly there seems to be a potential role for sleep for hyphenasal therapy in sleep apnea. So conclusions. I think we've seen that hyphenasal therapy has multiple advantages over standard therapy or oxygen therapy. In hypoxic respiratory failure, the evidence is strong, that we need to be really conscious of deterioration in that setting, and that NIV remains the primary treatment modality for hypercapnic respiratory failure. However, I think we can also be confident in saying there may be a role for domiciliary high flow in multiple other patient groups, and the evidence is growing. Thank you very much for listening. Apologies for going on slightly longer than planned. If you have questions, please do contact me either on Twitter or via my email address. Many thanks.
Thank you very much, Dr. Astin, for a very informative and entertaining presentation around the usage of high flow therapy. We do have a number of questions which came in the chat during your presentation. I still invite people, if they have additional questions, to post them in the chat. For example, and I think it's not specified, but I think it's about the studies you mentioned from the group from Braunlich. The question is, the study just did a crossover. Would there be also a place in COPD patients as for the one for the post-extubation patients to combine NIV and high flow nasal therapy at home? For example, nighttime NIV, daytime high flow.
Yeah, and I think that's a really interesting question. And the reason I put those slides up about the post-extubation group is very much to speak to that question. I think we should be considering high flow nasal therapy potentially as a combination therapy. There are certainly advantages to be had when using it above and beyond oxygen therapy in the acute setting, so there's no reason to believe it wouldn't be the case in the chronic setting. And I think with the evidence regarding airway function as well as CO2 clearance, I think there's certainly value to be had in running a trial looking at the very question, NIV plus high flow versus NIV plus oxygen or LTOT. There aren't data to speak to that at this current time.
Thank you. And then a number of more practical questions, I think. A lot of those came in also, like, for example, does the size of the cannula has an impact on the treatment and or the patient comfort?
Yeah, it very much does. And I think the maybe initially surprising answer is that we do not want to occlude the nostril. So a lot of the benefit of high flow nasal therapy is around that clearance. And by occluding the nostril entirely, it impacts on that. And that study from Braunlich, looking at the 4 different settings for high flow, with 1 prong in, 2 prongs in, and so on, really demonstrates that. So it's important to size the cannula appropriately, and usually with whichever kit you're using, there will be instructions with that kit. So it's important to consider that. In terms of comfort, again, patients tend not to like too snug a fit. So something that rests easily within their nostril is not only beneficial from the physiology perspective, but also from the comfort perspective.
Thank you. A question also, if there is no availability of supplemental oxygen, can we use high flow nasal cannula without oxygen? And if so, how could it be potentially better than NIV?
Yeah, so there are devices that will use the flow generated by air rather than oxygen. So in that setting, you're going to have humidified, very well humidified air at high flow rates. So you're still going to get the benefits of flow. You're still going to get the benefits of the humidification, but you won't be supplementing the FiO2 particularly. But if that's not the problem that you're trying to overcome, then it won't be such of an issue. So there's still, I think, great benefits to the supplemental flow, and particularly that humidification. It's a pity that it's so hard to demonstrate the benefit of humidification, because in our world of evidence base, it's a challenge to make that argument. But I think by putting together the evidence that is there, you start to tell a story. There are other studies that I couldn't present, one by Claudia Crimi, looking at using high flow in the acute setting of bronchiectasis, and again looking at impact, showing that there's increased sputum production, which in that setting is a positive. So, and that really relates to the humidification more than anything else.
Okay, thank you. I do acknowledge that we're running over time, but there are still a lot of questions here on the chat, so I hope everybody's fine continuing for a few more minutes. Also, an interesting question I think here is like, how do you wean patients from high flow nasal therapy? Do you wean flow and oxygen at the same time, or is there a stepwise approach or a protocol?
So I think that comes down to the pathology you're treating. So is this a hypoxemic patient that you started therapy to generate a higher FiO2, or is there a degree of worker breathing that you're treating? So I think it's considering the patient first and the problem first. However, generally, when delivering therapy in the acute setting, you're going to be titrating the FiO2 to the saturation aim. So rather than thinking about weaning, if we have the right saturation aim, the FiO2 will be titrated accordingly. So when we think about the weaning, it really is the flow that we're thinking about. And certainly the protocols that I developed for my institute in COVID treatment, we talked about two things. One was reducing the flow in trials. So we reduced 5 to 10 litres for 15-minute trials, looking at worker breathing and respiratory rate, particularly, as well as saturations. And that's partly as a wean, but also as a way of identifying whether the patient is improving or deteriorating. So with the patient remaining on a set flow in FiO2, it's difficult to know whether their underlying disease is improving or not. You can only uncover that by taking them off therapy. Now, with NIV, we have that that ability to see how bad the patient is, because they can't tolerate NIV continuously. So they have to come off the mask, and then you are forced to see how they are without that support. Whereas with high flow, because it's so well tolerated, unless you sort of artificially introduce that break, you don't see their underlying pathology. So we were keen to make sure we put in place in our weaning plan or our treatment plan a period whereby we do reduce the support so that we can assess the underlying work.
Very interesting, thank you. As you mentioned COVID, there is also a question in regards or related to your experience with COVID. Did you notice a difference with regards to retained secretions for your COVID patients who were on high flow therapy versus the ones that were on oxygen or CPAP alone?
Not particularly, although it's a little bit more complicated than that insofar as, well, first of all, I'd say that in COVID, secretion generation and retention was not their main issue, and perhaps not as big an issue as in lobar pneumonias or other settings. That's not to say that secretion management wasn't important, but if I was choosing an endpoint in a trial, it wouldn't be that in COVID. I think the complexity is around how high flow was employed within COVID. In my institute, for instance, we used high flow particularly for patients who did have high secretion loads or secretion clearance issues, knowing that the humidification would be more effective. So you're biasing the use and the outcomes. And I think that is also seen in a lot of the data presented in the COVID setting, that the general story is that I think high flow can be effective in COVID pneumonitis, but probably for the less severely affected. Most of the trial data, or say trial data, most of the published data seems to show that people chose to use high flow in the less severe end of the spectrum.
Okay, we have 2 more questions, I think. Would you say that we need better studies looking at the effects of high-flow nasal therapy in general?
Yes, although I think there are some good studies out there. I think many groups have made great efforts to acknowledge the limitations in data over the last 10 years. Certainly for the first part of the last decade, there was case reports on case reports and very little randomized controlled data. And it seems to go through that cycle of a question being asked and case reports being generated, and then retrospective studies, before after studies being published before you get to the RCT. So I think it's an interesting space. There are randomized controlled trials currently recruiting. I think in the next 2 to 3 to 4 years, we'll see a number of additional RCTs coming out that will more robustly answer some of the questions we've been asking in this presentation. But certainly there's a need for ongoing, particularly in the chronic domiciliary setting. I think that's a field where we're only just beginning to generate the data that we need to really support what is a potentially expensive additional therapy compared to standard therapy.
Okay, thank you. We're heading for the last question that came in. What clinically have you found is the greatest barrier for the patient? Is it the noise? Is there the tolerance to flow, or is it something else?
A mixed bag, and it's very difficult to predict. I've not been able to predict who might or might not tolerate, aside from those that are very claustrophobic and do not like anything on their face. But aside from that, very difficult to predict. It's often I find irritation at the nares, discomfort and intolerance of the temperature, even when used at a lower temperature of, say, 31 degrees. Some patients just do not find that. So I'd say discomfort predominantly. Flow, everyone's tolerance is different, and obviously it depends on their need. But we tend to, whilst I think I've just presented data suggesting on the whole, on the main part, higher flows are more effective, we never start at the very high flows. So we tend to start at a lower flow, 20, 25, 30, and work up, both to give the patient time to accommodate and experience the therapy, and also so that we don't surprise them with a high flow from the off.
Great, thank you. This concludes our Q&A session here. So my remaining task is, of course, once again, thank you, Dr. Astin, for this great talk, very informative, and taking the time also to answer all the questions we had from the audience.